Good afternoon, everyone. Welcome to our Women Veterans Virtual Town Hall hosted by Boise VA Medical Center. My name is Jennifer Pelaggi. I'm the Women Veterans Program Manager here at Boise VA. I will be serving as your moderator for today's event. Before we get started, I want to remind our VA hosts who are with me to please mute their lines unless they're actively speaking. Please note this town hall is being recorded for veterans to access who were not able to attend today. Also, a reminder, please don't share private medical information during the question and answer or in the submission box online. We won't be able to answer personal medical questions, but we do encourage you to discuss those with your VA medical team. We would love your interaction during this town hall. This is really for you and your questions and answers in the end. The first 25 minutes or so, you'll be hearing from some of our subject matter experts, and the second half is devoted all to Q&A. We have attendees who are on their phones simply listening and submitting questions, and we have other women veterans who are watching PowerPoint slides with the audio on a web link. For our phone listeners, if you'd like to submit a question during today's town hall, press *3 on your phone. If you would like to switch over to participate in this event online instead of by phone, you can press *8 to receive a text with the link. Those of you listening online, you can type your question into the online submission box. If at any time you would like to talk with a veteran crisis line, please press *0 and we will provide you with support and assistance. So that quick recap is press *3 to ask a question, press *8 to receive a link to participate online, and press *0 if you need crisis assistance. Next slide. Our facility leadership would like to welcome you to this call. It's my pleasure to introduce to you Dr. Andrew Wilper, Chief of Staff at Boise VA Medical Center. Dr. Wilper graduated from the University of Washington School of Medicine in 2003. He's been with the Boise VA since 2008 and has been a member of our executive team since 2016. When he's not here, he likes spending time with his family and in the outdoors. So I'm handing the microphone over to you, Dr. Wilper.
Thank you, Jen. Appreciate it, and welcome everyone. Thanks for taking time to dial in to this town hall meeting. I'm just going to give a brief overview of the Boise VA for those who have not been oriented to our services, so you have a bit of an understanding about what we do and who we are. The Boise VA covers quite a broad catchment area. So that's the geographic region that we serve patients in. It ranges from all the way from Salmon, Idaho into Central Oregon, the Hines VA. We have the main medical center here at the Boise campus, and then 5 satellite clinics that we call CBOCs, community-based outpatient clinics, and those are in Salmon, Twin Falls, Mountain Home, Caldwell, and Hines, Oregon. The bulk of our services are delivered here at the Boise VA, but we do deliver primary care, behavioral health care, and some specialty care at our satellite or CBOC clinics. The Boise VA employs approximately 2,000 employees, and we take care of approximately 45,000 patients in our catchment area. We provide a host of medical and behavioral health services for our veterans, and those include acute medical care here at the hospital. We have a 24/7 emergency department, inpatient units, an ICU, operating rooms, and then a host of outpatient services that include primary care, surgical specialty care, medical specialties, rehab and pain medicine, behavioral health care, and among others. At the women's clinic here, we have a dedicated freestanding women's clinic that is incorporated into the primary care service. And we have a number of folks who work in the women's clinic today. I'm happy to, who are on the call today. We have recently brought on board a new OBGYN, Dr. Quano, who we're happy to say is full-time and working here both in the women's clinic and in our surgical service. Some of the big developments that have impacted the Boise VA specifically in recent months is we've added some advanced technology to the services that we are going to offer. In particular, we're adding what's called Da Vinci robotic surgery. So that machine has been kind of ordered and actually is now on site, and we're building our kind of system to start doing robotic surgery here at the Boise VA campus to offer that service to veterans. We're also going through some changes here at the medical center, getting ready for a new medical record here in 2027. So just starting to kind of lay the groundwork for that transition where we'll move to what's called Cerner Oracle. A number of hospitals in our region have already transitioned to that medical record, and Boise is due to go live in September of 2027. And those are kind of the latest updates. There are generally a number of questions on these calls about community care services and eligibility. So in addition to providing a significant amount of in-person direct care to our patients, the VA also acts effectively as an insurer. So we pay for patients to go into the community, to private sector healthcare practices and hospitals to receive care that either we don't provide, or it's too far a drive to reasonably come in for. And I will just say that the national contract for our community care service is actually being renegotiated now. Those details are not known to me, but I'll just say that for those of you who do use the community care system, there may be some changes here in the next year based on whomever wins that contract. So with that, I'd like to thank you all again for taking time to dial in, and we have a number of excellent speakers today. And Jen, I'll pass it back to you.
Thank you, Dr. Wilper. Yes, we have a great featured speaker coming up in just a moment. I just wanted to reiterate that we have senior leaders here at the Boise VA that care deeply about our work with women veterans, Dr. Wilper included, and know that you have women's health specific leadership devoted to clinical excellence as well, and ease of access for you. So I am your Women Veterans Program Manager, so available to you. And on the line today to answer some questions is our Women's Health Medical Director, Dr. Heather Quinn. So you'll hear from her when those questions get rolling later. As a reminder to our audience, if you are on the phone and you want to submit a question, hit *3. If you'd like to switch over to the event online, you can hit *8 to receive a text with a link. And if you need to talk with a Veterans Crisis Line, press *0 and we will get you that assistance. And Dr. Wilper did a really good job of going over the variety of services that we have available to you, but just know that we have a full suite of comprehensive women's health care and consults available to you, including nutrition and weight management, whole health, gynecology he mentioned. We have a women's health pharmacist and many more things. So just know that we're here to make sure that we're provide you everything that you need in terms of your primary and specialty care. So we are excited to have a special guest for you today. It is Heart Health Month, so we invited Dr. Jennifer Pinzotti, who is our Medical Director of Boise VA Cardiology. We wanted to make sure our women veterans received a brief update with heart health education. She's been with the Boise VA since 2024, but with the VA in general, much longer. She attended medical school and residency at the University of Chicago and her cardiology fellowship at the University of Michigan. And she served at the VA in Madison, Wisconsin for 18 years prior to coming here. In her spare time, she loves to cook and she likes to go walking, running, hiking with her dogs. So I'm going to hand the microphone over to Dr. Pinzotti, and the floor is yours.
Okay, thank you very much for that introduction, and I am delighted to be here this afternoon to talk to you all about women's heart health and about some of the cardiology services that we provide here at the Boise VA. You can go to the next slide. So I'm going to start with a question. You can think about how you would answer this. So true or false, women are more likely to die of breast cancer than heart disease. And I think the answer is probably already up there. So that is false. Heart disease is not just a man's disease like we used to think that it is. It is the leading cause of death in women. About 1 out of 3 women will die from heart disease. And this is more deaths than all cancers combined, including breast cancer. About 1 in 39 women die from breast cancer. But still, many women think that breast cancer is actually their bigger risk. Next slide, please. So in response to this gap in knowledge and awareness and lack of research on how heart disease affects women, back in 2004, the American Heart Association launched their Go Red for Women campaign. And it's very fitting that we're talking about heart health this month because, as you mentioned, February is American Heart Health Month. Next slide. So I'm going to start with some kind of sobering statistics on veterans' health, and in particular women veterans' health. So compared to the general population, veterans, both men and women, have higher rates of several of the risk factors for heart disease, including obesity, diabetes, high blood pressure, high cholesterol, and tobacco use. And the news gets a little bit worse for women. So compared to their male counterparts, female veterans also have higher rates of obesity, diabetes, high blood pressure, and tobacco use. But the good news is that you can reduce your risk, and this is where knowledge is key, and I'm going to be talking to you about some of those risk factors. Next slide. So what is heart disease? Well, there's several different forms of heart disease. Most common one is coronary artery disease, and this is what I'm going to be talking about today. This is a type of heart disease that causes heart attacks, but there's also heart rhythm disorders like atrial fibrillation, there's heart failure or CHF, there's structural heart disease, valvular disorders like aortic stenosis, and congenital heart disease or heart disease that you're born with. Next slide. So a heart attack occurs when blood flow to a section of the heart muscle becomes blocked. And this is most often the result of atherosclerosis or buildup of cholesterol plaque in the coronary arteries. The heart muscle that's supplied by that blocked artery then dies. That's what a heart attack is. There are several different risk factors that influence the development of these cholesterol plaques, and I'll be talking about those today, things like smoking, diet, family history. Unfortunately, most people don't experience chest pain until their arteries are pretty severely blocked, generally greater than 70 to 80%. So you may not have symptoms until you're pretty close to getting into trouble, and that's why it's really important to work on prevention. Next slide. So what are the symptoms of a heart attack? Well, the most common one, of course, is chest pain. We call that angina, and it's classically described as a pressure sensation, a tightness, or squeezing. Some people will say it feels like an elephant sitting on their chest. And it's often associated with other symptoms, most notably shortness of breath, sweating, sometimes dizziness, palpitations, nausea. And unfortunately, women, of course, are more likely to have atypical or unusual symptoms of chest pain. So chest pain that doesn't fit that classic description, and this can make it harder to diagnose heart attacks in women. Next slide. We have a saying in cardiology that time is muscle. So the sooner that you come in and get help for a heart attack, the less heart muscle damage you'll suffer. So it's important to know the warning signs, and if you do think you're having a heart attack, call 911. Definitely don't get into a car and try and drive yourself to the hospital. And it's not even a really good idea to have someone else drive you. It's better to have the ambulance come to you so they can start treating you right away. And don't be worried about a false alarm. These things happen. We'd much rather see you in the emergency room and tell you everything looks good than have you wait at home through a heart attack because you're embarrassed. Definitely don't hesitate to come in if you think you're having a heart attack. The treatment's going to include medications to help stabilize you. It may include procedures like angioplasty, which is where we bust open the blockage with a little balloon, or it may include bypass surgery. Lifestyle changes are definitely going to be key to recovering from a heart attack and preventing future heart attacks. Next slide. So I'm going to be talking to you today about what those risk factors are for heart disease so you can work on prevention. So there's a lot of different risk factors, and some of them are under your control and some of them are not. So for example, you can't control how old you are. You don't get to pick your parents, so you can't control your family history. So if you do have some of those unmodifiable risk factors, it's super important that you control all the things that you can control, so the modifiable risk factors. Next slide. Of those modifiable risk factors, the most important one is smoking. This is the most significant risk factor, and it also increases your risk of a whole lot of other diseases that you don't want to have, like peripheral vascular disease and many cancers. But the good news is quitting does help. Your risk starts to drop as soon as you finish that last cigarette. And any form of tobacco, so whether it's vaping, chewing, any form of nicotine, these all increase your risk. So it's best to avoid tobacco or nicotine altogether. And regarding marijuana, as we're learning more and more about the effects of marijuana on the heart, it's not good news. So we're really not recommending that there's any safe level of marijuana use in terms of the risk of heart disease. Next slide. So the new dietary guidelines just came out last month. This is hot off the press. There's a lot to unpack in these new guidelines, and as a cardiologist, there's a lot that I like about the new guidelines, and there's a few things that I'm a little less certain about, a little less eager to get on board with. So one of the things that I do like is their very first statement, which is eat real food. We have a mountain of evidence that suggests that eating a diet that is high in heavily processed or ultra-processed foods is not good for your heart. It's not good for your body in general. So what I tell my patients is try to eat foods as close to their natural state as you can. So if it looks like something that you could probably cook in your own home kitchen, that's going to be better for you than something that you would clearly need industrial equipment to make. So eat real food. And I also like the fact that they remind us to limit added sugars and refined carbohydrates in our diet. That's really good recommendation for your heart. One of the things I'm not so sure about is this emphasis on foods that are high in saturated fats. So things like red meat, full-fat dairy products. If you look at the food pyramid, there's a weirdly enormous stick of butter very prominently placed in the middle, and it looks like the olive oil is kind of trying to hide behind things. It really should be the other way around. Next slide. The diet that we recommend as cardiologists that has the most evidence for it in terms of being heart healthy is the Mediterranean diet. And the emphasis here is on eating lots of fresh fruits and vegetables. So your diet should be predominantly plant-based. When you do eat protein, it should be lean sources of protein. So things like fish. Fish is a really good heart-healthy protein, as are beans or legumes and nuts and seeds. Those contain a lot of heart-healthy fibers and heart-healthy fats. Olive oil should be your main cooking oil, so choose that over the butter or certainly the beef tallow. When you do eat grains, we want them to be whole grains. And as far as dairy is concerned, it's fine, but we generally would prefer the low-fat dairy, so you reduce your intake of saturated fat, which we know is linked to coronary disease. Next slide. We also want you to be as active as you can be. Your goal should be to do at least 30 minutes of moderate physical activity most days a week, so shooting for about 5 days a week. And when we say moderate activity, what we mean is things like brisk walking, something that gets your heart rate up, but it doesn't have you so out of breath that you couldn't have a conversation with somebody who is walking next to you. So we want you to do moderate physical activity. It doesn't have to be really vigorous. And there's evidence in studies in women that shows that if you do this regular physical activity, it can actually add years to your life. So think about what that could mean, as you might be getting close to the end of your life, to have those few extra years and what that could mean to you and your family. So get out there and be active. Next slide. In cardiology, we like to say know your numbers, and the numbers that we're talking about are your cholesterol numbers, your blood pressure, your hemoglobin A1C if you're a diabetic, or your risk of diabetes if you're not, and your weight or body mass index. So the decision to start cholesterol treatment is a very individualized one, and I would encourage you to talk to your providers about this. Make sure you're getting screened. and talk to them about your risk. So it's not just an absolute number, but they're looking at what other health issues you might have going on and making that decision. If your provider does recommend treatment, it's usually going to be a statin medication first, and really consider taking that. There's a lot of data behind statins suggesting that they're safe, they're effective, and they're well tolerated. So please consider taking them if it's recommended. Normal blood pressure is 120/80, and our goal is to keep everyone below a blood pressure of 130/80. And it's okay if you need to be on medications for this. I think a lot of women tend to feel like they're a failure if they need meds, and that's just simply not the case. There's a lot of factors that go into blood pressure, some of which you can control and some you can't. But try and keep your blood pressure nice and low. If you're a diabetic, your goal is to have your hemoglobin A1C as low as you can get it, but ideally below 7%. And if you're not a diabetic, make sure you're getting screened if you have risk factors, and those include a family history of diabetes, diabetes during pregnancy, or being obese. And you should know your body mass index. So that's a calculator that you can easily find online, and it inputs your weight and your height. A normal BMI is less than 25. So for an average height woman of 5 feet 4 inches, that's less than 145 pounds. You're considered obese if you have a BMI of greater than 30 or 174 pounds for an average height woman. So talk to your provider about ways that you can get to a healthy body weight and maintain that. Next slide. So the recommendations regarding alcohol have evolved quite a bit over the years. We used to recommend a glass of red wine as a heart-healthy habit, but the more we learn about alcohol's effects on the heart, the less we really feel like there's any safe level of alcohol in terms of your heart risk. Our current guidelines recommend less than 1 drink per day for women, but if you're not drinking at all, there's really no good reason to start. It's not really considered a heart-healthy thing to do anymore. Next slide. We want to encourage you to talk to your providers about your risk for heart disease. And it starts with your primary care provider. Talk to them about what you're concerned about, what your lifestyle behaviors are, and they can order any screening tests that you need, and they can also refer you to us in cardiology if they feel you need to see us. And know that we sometimes will recommend that you have some additional testing before we get you scheduled into clinic. This helps us make the most of your time with us in clinic if you do need some testing done in advance. Next slide. So this is an overview of the cardiology services that we offer here at the Boise VA. We have a fantastic cardiology clinic. It's called the Green Team. I'm not sure why it's not called the Red Team, but it's the Green Team. And it consists of 2 cardiologists, that's myself and Dr. Tim Moore, and we have 4 excellent advanced practice providers, that's PAs and NPs, and 3 great clinic nurses. We offer a full array of cardiac testing, including echocardiography, which is ultrasounds of the heart, stress testing, and that's both exercise or treadmill-based stress testing, as well as medication or pharmacologic. We do ECGs and cardiac rhythm monitors, and we have a cardiac catheterization lab where we can do diagnostic angiograms or injecting dye into the heart arteries to look for blockages, and we can also perform angioplasty, which is putting in those cardiac stents if you need them. We have a cardiac device clinic, which monitors patients with pacemakers and defibrillators, and we have a fantastic home-based cardiac rehab program to help people recover from cardiac events. And we do have good relationships with the cardiologists in our community care partners at places like St. Al's, St. Luke's, or High Desert. And so we have the ability to refer you to them for things that we cannot offer here at the Boise VA. Next slide. So that's all I have to cover today. So just a reminder that, prevention begins with you. So it's just take one step at a time, work on replacing your unhealthy habits with healthier ones, eat for a healthy heart, and be as active as you can be. And I'll be happy to answer any questions that you have. Thank you.
Dr. Penzotti, are you still on?
I
Sorry, this
am.
is
Can
Jennifer.
you hear me?
Sorry.
Oh.
Okay. Okay.
Jennifer Palaci started talking and she didn't have the mute off. Anyway,
Okay.
I wanted to tell everyone that we definitely have a few questions coming in that are cardiac. So, Dr. Pinzotti, stay on the line. We have some other questions too. This is the time for you, our audience, our women veterans, to submit questions because we'll spend the rest of the time and trying to answer your questions. So, how you do that is if you're on the phone, you press *3. And if you are on the online, if you're on your computer online, you could submit your question in an online submission box. And I would just buy one more minute from you. I wanted to go over a few public service announcements. First, it's really important to us that women veterans feel safe and supported at all of our Boise VA locations. If you ever experience harassment, please contact our patient advocate at 208-422-1034. That's 422-1034, or contact the VA police at 208-422-1122. 422-1122. And actually, that does, I think, address one of the questions I saw come in. So we'll go over that again in just a moment. The next thing I wanted to mention of a few things, make sure that you know our Veterans Crisis Line resource. You can dial 988 if you're having anything to do with mental health, stress, or outright crisis. Anything along the spectrum, you can dial 988. Press 1 for veterans. You can text 838-255. It'll go to the same resources for the Veterans Crisis Line. And you can even chat online with them at veteranscrisisline.net/chat. So lots of ways to get to that help when you need it. There's going to be a Veterans Resource Fair in Twin Falls at the College of Southern Idaho on February 18th. That's February 18th from 9 a.m. to 4 p.m. We had a great turnout of veterans last year, and I would love to see you there. I will be there, and another one of the nurses who's on the line is going to be there doing some outreach with you. And then my final announcement, there is a new menopause group class. And it's 3 sessions that are part of the class, and that's being offered in April. And it's available remotely using VVC. So anyone, anywhere could get connected to this class if they're interested in it. It's called Menopause, Memory, and Me. And it's for those who are curious about premenopause, perimenopause, or postmenopause. So it's really for a lot of people. If you want to register, you call Anna. Anna is at 208-422-1145. That's 422-1145. You can always get in touch with me, too, if you have any questions about these things. So now we are ready to begin our Q&A session. We already have some questions that are lined up for us. Again, one more time, so I'm not remiss. If you're on the phone, you can press *3. If you're online on your computer, you can type your question into the submission box. And we have several people on the line to answer your questions. I'll do my best to read them off, and we have a variety of people who will answer them. So I wanted to start off because I saw some cardiac questions come in, and I know we have Dr. Pinzotti here today. Okay, on the phone, Dr. Pinzotti, you might see this from Janet. Is there any general recommendations for cardiac screening if you are asymptomatic?
Yeah, that's a great question. So if you're asymptomatic, again, it really comes down to that slide that I showed with knowing your numbers. So we always want everyone to be getting usually annual cholesterol screening, getting their blood pressure checked at least once a year, but potentially more often than that, especially if you have a history of high blood pressure. And then screening for diabetes kind of depends, again, on your risk factors for that. And then knowing your BMI or body mass index, which again ties into your weight and your risk for obesity. Those are the main screening tests that we do for somebody who's asymptomatic. Now, depending on what the results of those are, we may recommend some additional screening tests in order to further risk assess you if you're kind of on the borderline, for example, for needing medications for cholesterol. But those are the ones that we start off with. We generally don't recommend doing things like stress tests or echocardiograms in people who are asymptomatic or don't have any signs or symptoms of active coronary disease or cardiac disease.
Thank you, Dr. Penzotti. And related to that, I'm just going to go ahead and on the phone, Angel had left a similar question, related question. Are the cardiac clinics only available for women who are having symptoms? So kind of related to that question. Can these clinics be used by women for prevention? Why are we not screening for diseases before our annual exams? Labs need to be mandated. So do with that what you will.
Sure. So generally, we use the cardiology clinics to manage patients who either have active symptoms or have active cardiac disease. And primary prevention really is within the realm of primary care. So that's where you should start in terms of primary prevention, would be with primary care. And certainly talk to your provider about what labs they recommend for you. So and how often they should be checking those. And again, some of that depends on your individual risk for heart disease as far as which labs get done and how often.
Thank you. There's
I do want to, if it's okay, there's a
go ahead,
oh sorry,
please.
Go ahead.
Yes. No, go ahead.
Okay, I'm noticing a lot of questions coming through about statins. And I do think this is something that's worth just a quick mention. There
Absolutely.
is a lot of information about statins online, and unfortunately a lot of misinformation and disinformation about statins. There are a lot of studies, and literally tens of thousands of patients that address the safety and efficacy of statins. And yes, there are a lot of misinformation about them causing cancer, causing diabetes, a whole lot of things. Talk to your provider about your concerns, but I would really encourage you to listen to what your provider has to say. A lot of the information out there online just isn't based on good scientific evidence. As far as alternatives to statins, if you truly are not tolerant of statins, yes, there are alternatives. We favor statins as first line because we have the best evidence for them that they work in preventing and treating coronary disease. So there's other medications like ezetimibe or Zetia that are second line, and then the injectables as well. We call them PCSK9 inhibitors. Those are alternatives to statins if you truly don't tolerate them.
Okay, great. Thank you. Maybe before you get off that topic, I want to make sure there's a question that asks, does cholesterol medicine cause dementia?
Actually, it's generally the opposite. So what we're learning about dementia is often caused by what we call small vessel disease, not always, but sometimes. Mm-hmm. And so making sure that you get your cholesterol under control can actually help with dementia. So thus far, the cholesterol medications themselves have not been linked to causing dementia.
Thank you. Let me give Dr. Penzotti just a quick break, and I see a question online from Mindy. It says, does the Women's Clinic offer hormone testing and hormone replacement therapy for perimenopausal and menopausal veterans? And I'm thinking Dr. Heather Quinn may be up for answering this question.
Hello, everybody. I'm glad you called in. And yep, that one sounds right up my alley. So short answer, yes. All the women's providers, not just the ones at the Women's Clinic, offer hormone treatment for perimenopause and menopause symptoms when it's appropriate. And yes, we do hormone testing when it's needed. I think I don't want to set up unrealistic expectations, though. There are a lot of online recommendations and influencers who push very hard for full hormone panels, which we don't even know exactly what those are. They're not recommended by Endocrine Society or the Menopause Society, so we order hormones when they're going to change our management and when they help us figure out what's going on with somebody. So I just needed to clarify a little bit about hormone testing because there are places where hormones need to be tested and there's others where we have no evidence that it's helpful. But yes, treatment's available and we're here for you.
Thanks, Dr. Quinn. This is Jennifer Pelagi. I'm going to answer a couple quick questions. One is the VA reaching out to women veterans who joined starting in the 70s regarding sexual harassment? So first of all, I wanted to make sure that I reiterate that we take harassment very seriously. at the Boise VA. And if you have are experiencing any harassment at any location, please you can contact me. You'll have, in fact, I'll put my slide up at the end so you can contact me. You can contact our patient advocates at 422-1034 or the VA police at 422-1122. Now, we also have a robust military sexual trauma program within our larger behavioral health program. So if you know someone who needs a referral, let them know that there's multiple ways in, whether that's through your PCP or even if you don't have, if you're not enrolled and have a PCP here, you could still have access to the military sexual trauma program. So just wanted to mention that. The second thing that I wanted to mention is Anne asked, how do we find a women's health primary care provider through our local VA clinic? That's a great question. I love to answer it. At the VA, we have women's health designated primary care providers. All of our primary care providers can provide comprehensive care to any veteran, but we do have a special designation for providers who are doing extra training, extra education, and they're called women's health primary care providers. We have them at every location from the main campus to Silver Team, Gold Team, Orange Team, to our outlying clinics from Hines, Oregon to Salmon, Idaho. And so when somebody enrolls in the VA, or maybe they just don't realize until later that they might want a women's health primary care provider, we have about 35 of them. When they get enrolled, that clinic will reach out to them and offer them the opportunity to have a women's health primary care provider. If that was not offered to you, you can certainly call in and request one. So we'll take that question down. If you have more questions about that, you can let me know offline. Okay, let's get back to Dr. Penzotti. We let her rest there for a minute. When is it, let's see, Terry says online, when is it that a cardiology angiogram is needed? When is it felt that a cardiology angiogram is needed?
So just to review, a cardiology, an angiogram is basically when we inject dye into the heart arteries looking for blockages. So it's what we call an invasive test, meaning that we have to put a catheter into an artery. So it does involve not high risk, but not we want to make sure that we're using those procedures for the patients that really need them, where the risk of doing them is justified. So typically, we would be doing that in somebody who is having a heart attack, definitely, then we want to do it as quickly as possible, or in somebody who's having or has abnormal stress testing. And so we need to do that next level test. So we have a very high degree of suspicion that they have significant blockages in their heart arteries, and therefore we can justify the risk of doing that invasive procedure. So it's definitely not a first-line procedure, except if you're actually having a heart attack. So that's when we do that.
Thanks. Katie asks a question, I think, Dr. Wilper, you were taking this one. Is it necessary to ever update eligibility or do the annual IRS taxes take care of our eligibility?
Thanks, Jen, and thanks, Katie, for the question. Can you hear me okay?
Yeah.
Okay, very good. Katie, that is a complicated question. So I'm just going to walk folks on the line through how VA healthcare eligibility is determined. The very short answer is the best thing is to go into the enrollment and eligibility office with your DD-214 and potentially your most recent tax return, and they will help you. But they'll help you determine your eligibility for your year and circumstances. But the longer answer is that it is based on a number of factors, including your military service and discharge status, service connectedness, income and financial needs, and then other special statuses that they take into account. You have to have served in the active duty military and have an honorable discharge. And the VA expects 24 months of active duty completion or that kind of an obligation, with exceptions for people who are discharged for disability or hardship or other reasons. And then there's been new legislation passed in the last couple of years that kind of enhance eligibility via the PACT Act. That basically says if you've had certain kinds of exposures, your eligibility is kind of broadened. National Guard and Reserve members usually must have been called to active duty and completed an active duty period to be eligible for VA benefits. And then there's a whole process whereby the VA takes into account service connectedness and disability rating to determine kind of what you're eligible for at the VA. Those with greater than 50% or higher service-connected ratings, total disability, or certain honors or awards like a Medal of Honor or Purple Heart are placed in the highest priority groups. And then the next kind of categorization is income and financial need. So income doesn't necessarily determine if you can enroll in the VA, but it can influence your co-pays and which priority group you're placed into. So the VA does a financial assessment. People with low income are given a higher priority and essentially access to VA services. And then eligibility effectively can change depending on your income. That gets back to your kind of original question. And I have, in fact, had patients of my own who have lost their VA eligibility because they made too much money the year before, and they're always surprised, as am I, that that can happen. But there's basically a complex formula that includes your service record, discharge status, disability status, and income and financial status, in addition to the special exposures or awards that I mentioned that go into determining your eligibility. So after that kind of longer explanation, I would just come back to my recommendation, which is if you have a question about your own eligibility or eligibility of a family member, I would just get with the enrollment and eligibility office here at the Boise VA. You can call in, make an appointment, and they'll want you usually to bring in your DD-214 discharge paperwork and your most recent tax returns, and they will help you kind of help guide you through the eligibility determination. Thanks.
Thanks, Dr. Wilper. We have, it looks like a little bit of a repeat. We have Kelly who wants to know, Dr. Pinzotti, could chronic neck pain be related to heart disease?
The answer to that is always going to be maybe. It certainly depends on the nature of the pain. So again, women, as I mentioned, can have very atypical or unusual symptoms of what we call angina or heart-related pain. And sometimes, yes, it can be the pain that is just located in the neck. Sometimes it travels down the arm. Things that you would want to watch out for is, does it get worse when you get up and walk around and better when you rest? And is it associated with any other potential heart attack-related symptoms like shortness of breath, sweating, feeling nauseated, feeling lightheaded, or having palpitations? Definitely, if you're worried, talk to your provider about it, or come in and see someone.
Thank you. We have a concern, as we have a woman veteran in Twin Falls having some trouble getting community care referrals in line. She recognizes, and we do have some people who are dedicated in our community care office for taking care of women veterans, but she's having some trouble getting a call back and getting that nailed down. And we have a few questions around that. So that's how I've summarized it. And Norca, I think you're on the line. Who could she contact, or who could get back in touch with Kippy about that?
So depending on, I guess the short answer is contacting our program office, the 422-1000, and asking the operator to speak with community care. Depending on where we are in the referral process, will help guide who best can help answer that question. But that's the best start, at least, so that someone within our office can take a look at the referral or consult and make a determination as far as what are the next steps, whether it's approval, whether it's coordinating care, scheduling an appointment, things of that nature.
Thanks, Norca. And for Kippy, if you continue to have a question around that, again, I'm a resource for all of you women veterans. So if you just ever have a lingering question, a hurdle you can't quite get over, you can contact me. I did put my contact information on a slide there, but if you're just listening on your phone, my number is like the main number 422-1000, and my extension is 7442. 7442. That's Jennifer Pelagi, and so Women Veterans Program Manager, so can help with things like that. And Norga and I and all the rest of us work closely together, so we just get in touch with each other to iron out those things. All right. Let's see. Is there? Oh, let's see, Dr. Pinzotti. There's a few things here, and they're probably in front of you too. But is there any? Maybe help spell out this acronym: POTS Education or Lifestyle Programs.
Okay, so POTS stands for Postural Orthostatic Tachycardia Syndrome, and it's definitely one of the more misunderstood cardiac syndromes, and can be very, very frustrating. It can be frustrating for patients to get accurate diagnosis, and unfortunately, there isn't a lot of great treatment for it. To describe what it is, it's basically when you have kind of an abnormally vigorous heart rate response to going from positions of laying down or sitting down to standing. So it's normal for your heart rate to increase when you do that because, obviously the blood tends to pool in your legs, and when you stand up, you need to get that blood up to your brain where you need it or you'll get dizzy. And some people can have a very vigorous response to that where you get very tachycardic or very fast heart rate, and it just kind of stays there. So most of the time what we'll recommend are kind of some lifestyle things, and if those don't work, there are some medications, but my experience is that most women don't find them to be terribly helpful, and sometimes they don't really tolerate them very well. So definitely, if you think you have this, reach out again first to your primary care provider. They can certainly refer you to us if they feel you need to see us, and we can make some recommendations there. But so we do see that from time to time, and yes, it can be a very frustrating diagnosis to deal with. So don't hesitate to reach out.
Thank you. And I just wanted to do a time check, let everybody know we have about 10, 12, 13 minutes left, and if there are remaining questions, I will stay on the line. The rest of the panel will need to end, and after that, you can be in touch with me with questions, and I can get you in touch with the right people. Nikki had asked, how can we get a copy of the slides? Nikki, you can get them from me. You can call, but my email here at the VA is jennifer.pelagi, P-A-L-A-G-I, @va.gov, and you can also just Google Women Veterans Program Manager, and it'll take you. There's one of me at every VA in the country, and so it'll take you to the one here, and you can reach out to me. I'll get you those. Okay. Let's see. There's a few things around nicotine patches, nicotine, marijuana. So let's go to Crystal's question online. Do marijuana edibles have the same association to a greater degree of heart disease versus smoking marijuana?
I'm not a marijuana expert, and we're still learning a lot about the effects of marijuana on the heart as we're kind of in the midst of this uncontrolled experiment with marijuana getting legalized in many places across the country. And, so I think I don't have a great answer to that. We want to kind of believe that smoking it is probably worse, but I don't know that for sure. And I think, again, as we're learning more about not just the risks of marijuana, but the potential benefits of marijuana or lack thereof, we're starting to realize that it may be, as we study it better, it may not be quite the miracle drug that we kind of thought it might be. So I would say, be careful with it, and really weigh for yourself the risks and benefits. But from a heart standpoint, I don't think that I can say that there's any safe level or safe form of it at this point. We need to study it more, and hopefully we will study it more. So I do think it merits study.
Thanks. And it looks like
nicotine
Joanne's
patches.
asking,
Sorry.
nicotine patches. How do nicotine patches affect the heart?
So the nicotine that you get through a patch, I mean, it's the same nicotine that you get through a cigarette, but the difference is that it doesn't come with all of the other stuff. So in terms of, using nicotine patches to help you quit smoking, definitely, that's worth doing. If you need to do that to quit smoking, we would really encourage you to do that. But eventually, you want to get off the nicotine patches because nicotine is not a great drug for the heart. It raises blood pressure, it raises heart rate. So we really don't want you on any nicotine at all, ultimately. But if it helps you quit smoking, then it's good.
Thank you. Okay. Robin asks, Dr. Penzoti, can heart murmur lead to heart problems?
A heart murmur can be a sign of a heart problem. So if you do have a heart murmur, what we usually recommend is that you get an echocardiogram or an ultrasound of the heart, which is pictures of your heart so we can see if there's any issues with the heart valves. But know that there are a lot of what we call benign heart murmurs or flow murmurs. So it's not always a sign of heart disease, but it can be. So I think if you have a heart murmur, it's worth getting checked out.
Thanks. Okay, I'll give Dr. Penzoti a break real quick. Dr. Quinn, I think Edith asked, can we ask primary care providers for weight loss medications if perimenopausal and having issues losing weight and considered overweight, or do we have to go through other means?
That's a good question and a really common one. We have those conversations. I would say every one of us has them with probably about half our patients. The VA has some criteria for weight loss medications, and the ability to get GLPs, meaning the semaglutides and the tirzepatides through the VA is pretty restricted because of supply issues. But that being said, we really do want to sit down with our patients, have conversations, and present what options are available so that you can make a decision about which way to go. Some things are available through the VA and some are not.
Yep. Thanks. Thanks, Dr. Quinn. Let's see here. This might be for Dr. Penzoti and maybe even a little bit for Norca from Community Care. Elizabeth has a couple of questions related. Nervous about heart surgery. How do I find a reputable surgeon? How do I, as a patient, compare heart surgeons locally to make an educated decision on that kind of topic?
So
how do I make sure I'm getting the right heart surgeon?
Yeah. Without knowing the specifics about what the procedure is, I mean, I think the good news is we're lucky to be in Boise, and we really have access to a lot of great providers, including great heart surgeons, both at St. Luke's and St. Al's. So, as far as how you evaluate them, so, I mean, again, I think it's best to probably talk to, if it's one of us in cardiology that referred you, we can certainly give you our opinion. And sometimes it's just that one surgeon versus another maybe specializes in a certain procedure versus another. So some of that can help make a decision. So I think, it's best to probably go to whomever referred you to the surgeon and get their advice.
Mm-hmm. Great. We have a question, I think, Dr. Wilper, maybe you can help around the Nexus letter question. So if you're seeing somebody in behavioral health, like as a behavioral health provider, can they write a Nexus letter for their mental health condition? And I'm assuming that the veteran is talking about submitting a claim to the Veteran Benefits Administration, which is a separate arm of the VA, separate than the VHA. And I don't know, maybe you'd like to try to answer this, Dr. Wilper.
Yeah, and thanks for that, Jen, and thanks for the question. Mm-hmm. So it is important to know that the VA is a big federal agency made up of three smaller parts. One is the Veterans Health Administration, which is the hospitals, which is where we all work. And then there's the VBA, which is the Veterans Benefits Administration, which handles disability claims And then there's also the NCA, National Cemetery Administration, which handles death and burial benefits for veterans. So it's a tripart system. It is true that the VA healthcare providers can provide nexus letters if it's within their scope of practice to comment on kind of the origins of their disabilities and their healthcare history, and kind of make an estimate about the kind of the link or cause of their current problems based on what has happened in the past. So that the answer is sort of a qualified yes if the provider feels that it's within their their scope of practice to do so. I did see there was kind of a nuance to that one question, which was if the vet is pursuing the disability claim but never used the VA system for health care, can the VA provide the behavioral health provider to write a nexus letter? And I think in that case the answer is no. We do not generally provide health care to unenrolled veterans, so you'd have to first be enrolled to be able to see a VA behavioral health provider. We do, on occasion, provide humanitarian type healthcare to people who are not enrolled and even non-veterans on occasion, but you'd have to be enrolled to get that assessment and then talk to the provider about the nexus letter. I hope that makes sense. Thanks.
Thank you so much. Guys, we have about 3 minutes left, so we probably won't get to all of your questions. If your question wasn't answered and you would like it answered, just go ahead and reach out to me, jennifer.palagi, Palagi, @va.gov, or you could send a secure message as well. I'm in there as the Women Veterans Program Manager. So anyone that we don't get to, if you're chomping at the bit to get that answered, you just go ahead and reach out to me and we'll get that answer. But since we have a couple minutes left, okay, Dr. Pinzotti, what type of exercise is recommended if you're over 70 and have some physical limitations?
Great question. Really anything that you feel you can do. So let your body be your guide and tell you, when you're overdoing it. So, I think particularly in older individuals, some of the high impact things can be more difficult. So if you have access to a gym where you can use equipment where like ellipticals, it's easier on your joints. If you have access to a swimming pool, swimming is great because, it really takes that stress off of your joints. But the bottom line is, if you haven't been exercising regularly, just start low and go slow. So just do what you feel up to and gradually increase and work your way up to that 30 minutes most days a week of cardio, getting your heart rate up. It really, I always tell my patients that any amount of exercise is better than none at all. So even if all you do is get up and walk to your mailbox once a day, that's better than sitting on the couch. So just start with a little bit that you feel comfortable with and kind of keep working your way up.
Thanks. And I'll take one more question and then I'll do a closing comment or two. And again, just send your questions to me if you didn't get yours satisfied. Carrie says, I'm in Salmon. In the event I get referred to a specialist, ortho or gyne, would I be able to go to Missoula, which is closer, or do I have to go to Boise? I think, Norca, this might be a question for you in community care, even though it has to do with travel, too. And I'm not sure if Norca's still on. Oh, there she is. I know. Oh. There you go.
Yeah. And so maybe if we can, because it depends on your address. Sorry. It's complex because while depending on your address is how you're eligible for community care distance-wise. However, what VA clinic, specialty, or services are near you, even though you may not be enrolled, does affect whether or not you're eligible for community care distance-wise. You may be eligible for other modalities. So to look specifically, I would recommend reaching out to Jennifer, and we can do a better deep dive, and I can provide a better response and give a little more clarity to it.
Thanks a lot, Norca. All right, and I'm going to share one more. Donna says, wanted to thank you all for hosting and participating in these events and hope you will have more of them. Thanks again. Donna, thank you. We will have at least 2 of these large town halls a year for just women and 4 smaller focus groups. And we can have more, but that's at a bare minimum. So we want to thank you guys for coming. If you would like to leave a question or a comment for our team, besides contacting me, you can stay on the line and you will have an opportunity to leave a recorded message once we close the call. So we're totally committed to providing you with top-notch health care. If we aren't getting things right, please reach out to us and we will work on doing it better. This concludes our presentation. Thank you for your service, and we will see you at the next town hall or perhaps on campus. Thank you and have a good rest of the day.